in 5 minutes. We will be starting in 5 minutes. Meanwhile, please feel free to program implement. Welcome to today's session on strengthening IPC in program implementation at the national and facility levels. This is the second session in a series we started 2 weeks ago on strengthening IPC as an HR core capacity. I want to take the time to welcome all of the colleagues. We have a number of people here from a number of countries, including Kenya, from Ghana, from Togo. I'm seeing Sierra Leone, Zambia, MOH, Cote d'Ivoire. Thank you for joining us. So today we're going to start with a bit of housekeeping, as we usually do. WHO is committed to enabling events with inclusive, respectful, and safe environments. We are guided by the highest ethical and professional standards, and all participants are expected to behave with integrity and respect towards all of participants, including panelists and facilitators. So as we have the conversation today and as we ask our questions and interact, we're expected to do this respectfully. Next slide. We have interpretation in English and in French. If you look at the bottom of your screen, you're going to see a globe icon that's labeled interpretation. You click on that and you will be able to access French. And when we have a French speaker, either during the Q&A or during the session, for the English speakers, you can then also click on English so that you can listen to the interpreted version of that conversation. Please use the Q&A for questions regarding the topic and the presentations. And we can also use the chat for general introductions, questions regarding IT. If you need clarification on interpretation or any other thing, we can do it in the chat. We can also use the chat to share with you some important links, so you also have to pay attention to that. However, colleagues, may I emphasize that questions in the chat will not be attended to. Please put the questions regarding the topic and the presentations in the Q&A so that the panelists can attend to them in there. During the live Q&A session, the moderator is going to ask you to take the floor or ask for live questions. For that session, colleagues, you need to use the raise hand feature. If you look at the bottom of your screen, you're going to see a hand like this. You can either click on that, or for some other Zoom interfaces, you have to go to the React button and then click on that, and you also see the raise hand button. Next slide. By participating in this session as participant or as panelist, we take your attendance as permission to record your contributions, and we will be sharing the recordings via our various learning channels for continuous learning purposes. We'll be sharing the recording also with some of the presentations and other resource materials in the days following the webinar. Next slide. We have collected some very important data from you when you were registering for this session or when you were registering for the series. That data is kept confidential with WHO. We may use this data for reports, for communications, for surveys, or quality assurance. However, that data will be de-identified before it is used for these purposes. Next slide. I'm going to run you quickly through the agenda. My name is Amarachi Abianuru, and I've just done the welcome and housekeeping. We'll be taking opening remarks by Dr. Fred Kapaya very shortly, and then we will have the objectives, and the next session would be IPC minimum requirements at national and facility levels by Tendai Makamuri. We will also take infection prevention and control assessment tools for national levels by Dr. Landry Kabego. And shortly after, we would have a Q&A session that will be moderated also by Tendai Makamuri. We're going to take a country experience sharing by Sierra Leone, and they will be sharing their experience on their IPC facility level implementation. This will be done by Bobson Derek Fofana. Shortly after, we will do another Q&A, and have summary and expectations from countries by Tendai Makamuri. And we will close this session very shortly. We're hoping to have a 1 hour, 30-minute session, hopefully. And the session will be closed by Dr. Fred Kapaya. So very quickly, I will be handing over to Dr. Fred Kapaya for the opening remarks. Over.
Thank you very much, Amarachi. Good morning, good afternoon, good evening, from wherever you are joining. Distinguished colleagues and partners, welcome to session 2 of our IPC webinar series. I'd like to thank you for your continued commitment to strengthening IPC in our region. In our first session, we reviewed the global IPC targets and the indicators that countries are expected to report on, all of which are aligned with the IPC minimum requirements at both national and facility levels. Today's session builds on that foundation. For us to progress towards a strong, more resilient health system capable of preventing and responding to outbreaks, we must prioritize consistent and effective IPC implementation across all levels of care. Our theme today, Let's Not Build and Forget, reminds us that establishing IPC programs and systems is only the beginning. What truly protects our patients, health workers, and communities is ensuring that these systems are maintained, supported, and implemented consistently over time. This is especially critical in primary healthcare facilities, where most patients first seek care and where IPC gaps can allow small outbreaks to escalate rapidly. These frontline facilities must not be left behind. They require the same attention, investment, and routine support as higher level hospitals. As we revive the IPC minimum requirements, the Infection Prevention and Control Assessment Tool minimum requirement for the national level and country experiences today, I encourage us to reflect on one key question. How do we sustain what we build long after emergence, funding, and attention have faded? Let us use this session to reaffirm our commitment to embedding strong, everyday IPC practices across all levels of health system, ensuring that our progress is not temporary, but lasting, institutionalized, and impactful. Ladies and gentlemen, I would like to thank you, and I look forward to a constructive and solution-focused discussions. Thank you very much.
Thank you so much, Dr. Fred. Thank you for continuing with our mantra from last week. Let us not build and forget. I will now be handing over to Tendai Makamuri, who will be taking us through the objectives of the webinar and also the IPC minimum requirements at the national and at the facility levels. Over to you, Ms. Tendai.
Thank you very much, Amarachi. Can you confirm if you can hear me well and see my screen? So as said by Dr. Kapaya, we are continuing from the session we had last week, and our main objective here is to strengthen the implementation of infection prevention and control programs as an IHR core capacity. And we are hoping that this will help us a lot. If you remember from the previous session, we had gaps that we highlighted in the different assessments that are done on infection prevention and control. And our objective is that we make progress and we make improvements. So particularly on today's session, if we remember last week, we had a presentation on the targets that we are following, we need to report on the global strategy, and they are mainly aligned on minimum requirements. So building onto that, this session will focus on trying to have everyone to understand what the minimum requirements are at the national level and the facility level. And in addition to that, we are going to go through the tool which is used to assess the progress at the national level, which is what we recommend that countries be using to assess their progress of their implementation of the IPC program. And we are also going to have a session from Sierra Leone, where they are going to give us their experience on using the infection prevention control assessment tool for facility level, which is based on the minimum requirements, which is the tool that we are currently recommending to use, as it enables you to assess at the primary level, at the secondary level, and tertiary level. And we are also going to lastly outline the key summary expectations on how we are going to move forward in trying to align with the global goals and achieve them. Thank you. I think this is the first part. I will move and switch to the next one, which is on the infection minimum requirements for the national level. So, as I already said, we hope that we are able to understand what the minimum requirements are at the national and facility level and how they are different and also how they are correlated. We are also going to look at how we can use these minimum requirements to improve the existing programs that we currently have for IPC at the national level and facility level, and also understand why these minimum requirements are particularly important and why we need to put them in place. So what are these minimum requirements? We are saying the minimum requirements, these are the minimum standards that should be in place at the national and at the facility level to provide minimum protection and safety to the patients, to the healthcare workers, and to the visitors who come to the healthcare facilities. And they are based on the World Health Organization core components. There are 8 core components for the infection prevention and control programs, which we define as the wheels which are supposed to carry on the IPC programs. And we are saying these minimum requirements, they are where we must start from to build strong IPC programs. And as you see on this diagram, on the orange triangle, this is where we are starting from, and it represents the minimum requirements. So we must follow a stepwise approach and slowly progress to the full core components of IPC, which require more than what is recommended on the minimum requirements. But the baseline, we are starting from the minimum requirements. And we recommend that we use the stepwise approach in implementing the IPC minimum requirements. And this on the right, this cycle shows the stepwise approach which we must follow, which starts with the first step where we are preparing for action, and we are looking at the prerequisites that are required, the key players, their responsibility, the human resources, the infrastructure, and the planning and coordination that is required for an effective infection prevention and control program. For the baseline assessment, once we have done the preparation, we proceed to do the baseline assessment. And on the baseline assessment, we are evaluating the baseline assessment, the current situation, looking at the gaps, looking at the strengths, looking at the weaknesses. And for this baseline assessment, for the national level, we recommend the use of the standard tools, which is the first one, the Infection Prevention Control Assessment Tool for minimum requirements at the national level, which is going to be presented by Dr. Landry. And at the facility level, the recommendation is we do baseline assessments at facilities using the Infection Prevention and Control Assessment Tool for minimum requirements at facility level, which allows you to assess the primary, the secondary, and the tertiary care level. Once we have done the baseline assessment, we move to developing and executing the plan. The plan should aim to address the gaps that are identified in the baseline assessment and reinforce improvements and strengthen the already existing strengths that we have. Then on the step 4, we are now evaluating the impact of the plan. And again, on step 4, we use the same tool that we have used at step 2 to do the baseline assessment. And lastly, we do sustaining program, which is step 5 over the long term, where we are looking at the long-term impact and acceptability of the ongoing action plan and ensuring that is sustainable. So this is the recommended stepwise, and it's applicable for the national level and at the facility level. And we must bear in mind that the ultimate goal is that we put in place the minimum requirements, but while we are aiming towards the long-term goal of progressing to the full core components of IPC programs. And as I said, as a reminder, the minimum requirements is what is recommended for countries with limited IPC, and particularly for us in the African region where we are still struggling with finances and budget. We are advocating, let's start with the minimum requirements. Now we are moving into what are these minimum requirements. As I said, they are all anchored on the 8 core components of the IPC programs. And the first core component is the Infection Prevention and Control Program. At the national level, the recommendation minimum requirement is to have at least one full-time trained IPC focal point and a dedicated budget. And we are saying it must be full-time and not part-time. And these personnel will be trained in IPC, and they will also be the driver in steering the implementation of the IPC program, both at the national coordination, the national activities, and at the facility level, and they need a dedicated budget to support the implementation of IPC. Similarly, at the national level, we can also have an IPC committee, and you will see that it will function in supporting the core components number 4 on healthcare-associated surveillance, and also the implementation of IPC monitoring on the core component number 6. At the facility level, we are saying the primary care level in our facilities. This is the first main point of entry of infectious pathogens into the health system, and it is where IPC is usually the weakest. And we are recommending that we, at the primary care level, we have trained IPC link person with dedicated part-time in each primary healthcare facilities. They need to be responsible for routine implementation of IPC at the community, at the primary healthcare facilities, and also working within their communities. They're the ones who have direct contact with the community. They need to give the right information to the community healthcare workers, to the patients, to their caregivers, so they are also adhering to the infection prevention and control standards. And they are supposed to also have one trained healthcare officer at the next administrative level, whom they will be working with, who will be supporting them with implementation and supervision. At the secondary level, again, we recommend a trained IPC focal person. Depending on the size of the hospital, the recommendation is 1 per 250 beds with dedicated time for IPC activities and also dedicated implementation budget to support the implementation. And this is also the same for tertiary care level facilities. The second core component is on infection prevention and control guidelines. And at the national level, we need to have IPC guidelines which are reviewed and adapted every 5 years. Most of our countries, we have these guidelines, but we'll notice that most of them are outdated, and it is important that they are updated every 5 years so that they are in line with the current evidence and recommendations. And also, in addition to the general guidelines, every other time we are conducting strategic risk assessments in emergency preparedness, where we are identifying the particular risks, and each country is developing risk profiles. It is part of these IPC guidelines as part of the IPC program. They need to develop the disease-specific SOPs for the high-threat pathogens that the country has identified For example, if EVD is identified, Ebola virus disease is identified, we need to have them in place here as part, SOPs as part of the national guidelines, so that each time we have an outbreak, we are not starting with developing an SOPs. They should be in existence and part of the guidelines. And this should be disseminated to the healthcare facilities, where we are saying at primary care level facilities, we need to have evidence-based facility SOPs, which are based on the national guideline that is developed by the national IPC program, and they should at least cover the standard precautions and also basic principles of transmission-based precautions, so that at least when they encounter cases that are meet case definitions for infectious pathogens, they are able to protect themselves and to not amplify the spread of the diseases within the community and the primary care level. Similarly, at the secondary and tertiary level, we have all these requirements for the guidelines and the SOPs, but we are also adding detailed transmission-based precautions with the secondary and tertiary healthcare facilities offering a wider range of services and procedures. We are now adding also issues to do with aseptic techniques for invasive procedures, which are done during surgeries, and also SOPs to prevent healthcare-associated infections, which are based on the local context and epidemiology. The third core component is on IPC education and training. At the national level, there needs to be a policy for healthcare workers to have in-service training. We need to have approved IPC curriculum that is aligned with the national guidelines that we developed in the second core component, and they need to be approved. We also need the national program to have a system and schedule of monitoring effectiveness of training at least annually. Similarly, when we now move to the facility level, for education and training, we are saying all the healthcare, the IPC link we have mentioned, they should be trained in infection prevention control. All the clinical staff, the cleaners, the healthcare workers, they must receive training upon employment. So it should be a policy that on employment, all healthcare workers, primary, secondary, and tertiary care, there should be a policy that they need to be trained on infection and prevention and control. And this should be a policy at the hospital level. And they should be reporting these trainings to the national level. The fourth core component is on healthcare-associated infections. And we are saying at the national level, as I mentioned, on the multidisciplinary group that should be set up to support the surveillance of healthcare-associated infections. And it's really important that we have high surveillance, as it will help to guide on the strategies and priorities to assess the effectiveness or the impact of our IPC interventions. Otherwise, we are moving blindly. It's also important to have a high surveillance, as it will help us to detect outbreaks within healthcare facilities that we are working. And this multidisciplinary team at the national level, they should develop a national strategic plan on healthcare-associated infection surveillance, which is outlining the priority pathogens that they're going to do surveillance on, which should also outline the standard case definitions to be used, data collection, how they're going to be monitoring, and the whole cycle of data collection and feedback mechanisms as well. And if you remember on our presentation last week, this particular aspect was quite low in healthcare-associated infection surveillance on most countries, with most countries not having this strategic plan. So one just wanted to emphasize on this one. At the primary level care facility, high surveillance is not particularly required, but should follow national or also the sub-national level plans. Similarly, with the secondary care level, it should follow the national, sub-national plans. And at the tertiary level, we expect to have active healthcare-associated infection surveillance, enabling structures and supporting resources to be in place, and also timely and regular feedback to be given to the stakeholders in order to lead on where improvements needs to be, so that we reduce the incidence and we also improve our activities, our IPC interventions that we'll be implementing. The fifth core component is multimodal improvement strategies, and The multimodal improvement strategies are recommended for all IPC interventions and all the recommendations that are outlined in the guidelines and in the SOPs. And the IPC focal persons at the national level, at the subnational level, they need to be training on the multimodal improvement strategies. And we are saying, why are these multimodal improvement strategies important? They are very important because they are saying that we are not just going to use one activity, one method to implement activities. We need to look at the different strategies that we need to implement to create an enabling environment that helps to reinforce behavior change within the healthcare facilities. And we have, say, 5 components that make the multimodal strategy. We have the first one, which is the build it, where we are saying for us to be able to implement IPC, we need to have the appropriate infrastructure to enable adherence to IPC. The second one is on teaching it. We are saying we need to provide training and health worker, training and education to improve healthcare worker knowledge. The third one is check it, where we are monitoring. After we have done the training, we need to monitor, are they adhering to what they've been trained to the IPC recommended standards? And also we need to have in place reminders to enable the healthcare workers to adhere to the recommended standards. And lastly, to create a culture of safety where we have a change within the whole healthcare system and everyone is supporting the implementation of IPC and involved in the implementation of activities. As we remember from the presentation from Malawi, they have champions in all the departments within their healthcare facilities. They made sure that there's an IPC person to support that. And I can give an example for this multimodal strategy referring to hand hygiene. Build it. Do we have the infrastructure that is required to support IPC adherence? Do we have hand washing facilities? Do we have soap? Do we have running water? Do we have alcohol-based hand rub solution at every point of care to enable the health workers to adhere to hand hygiene? Teach it. Have we taught the healthcare workers how to practice hand hygiene at the indicated times and also at all points of care following the 5 moments of hand hygiene? Check it. We need to monitor observations as healthcare workers are providing care. Are they adhering to the recommended practicing hand hygiene at the indicated times before they attend to patients and as recommended in the 5 moments of hand hygiene? Selling it, we are putting the posters on hand washing in front of the sink to serve as reminders on the correct techniques that the healthcare workers need to follow when they are doing hand hygiene. Then the Live It culture, we have the whole hospital supporting, ensuring that we have supplies consistently to enable hand washing and practice hand hygiene. We also have the champions for hand hygiene. We are commemorating the hand hygiene days. This is an example of how we can use the multimodal strategies, and it can be applicable for all the IPC interventions. The 6th core component is monitoring and audit of IPC practice. At the national level, the same multidisciplinary team we talked about in core component 4 is also the one that should be responsible for monitoring the implementation of the IPC programs at the national facility level. They need to develop an M&E plan for facilities which has defined minimum indicators that the facilities are going to report on to the national level. They need to set up an integrated system for the collection and analysis of data, and also provide the tools and provide the training on how to collect the data and how to do the supervision. Similarly, at primary care level, based on the plan from the national level, they also need to know what they are monitoring at the primary care level. They are monitoring the IP structural and process indicators. Similarly, at the secondary level, there is also periodic and continuous monitoring of selected indicators. And here it's important to know that hand hygiene is a priority key indicator that needs to be monitored in all the countries. And in addition to just monitoring and evaluation, it's a cycle. There is need for timely and regular feedback to complete the whole cycle from the facility to the national level, and also backwards from the national to the facility level, so that we strengthen our programs. The seventh core component, which is on workload, staffing, and bed occupancy. These are, we're going to talk on the facility level on these ones. We are saying that at the primary care level, as we have said, this is the first main point of entry for infectious pathogens to the healthcare system. Therefore, at the primary level, we need to have systems in place to prevent overcrowding in healthcare facilities. And that means we have to have an efficient patient flow, referral systems, triage for the management of consultation. We also need to have optimum staffing levels because it also impacts adherence on IPC recommendations. At the secondary and tertiary care levels, we also need to have, similarly, in addition to what we have at primary level, where we are having ways to reduce overflowing and optimizing staffing levels. We are just now more, because there's more admission of patients, emphasizing spacing between beds, making sure that there's no more than one patient between the beds, and we have a system in place to establish standard bed capacities, and similarly to have in place adequate staffing levels within the secondary and tertiary care. And lastly, on the eighth core component, which applies to the built environment materials, equipment for IPC, this is looking at the infrastructure that we have at the primary level and the secondary level. And this is particularly important because we need to ensure that it's functional, and as part of our monitoring, to ensure that we always have these things in place. We have sufficient water that is piped inside the healthcare facilities, functional hand hygiene station, functional sanitation facilities, at least 2 in the primary level, and also the built environment of the infrastructure that allows for adequate ventilation to prevent transmission of pathogens. And hence why we emphasize that the IPC focal person, the IPC program, needs to be involved in the construction or in the designing of the healthcare facilities, working with the relevant departments within the government to ensure that we have adequate ventilation, and also as they are designing, we have space for, if it's at the primary level, we have some space for triage or for temporary isolation, so that if there is a need for isolating a patient we suspect to have an infectious pathogen, we are able to do that. We have the IPC supplies. At the primary care level, they at least need to have the basic packages for IPC supplies. And if we know that in those healthcare facilities, we are particularly prone to cholera, to Ebola, or to Marburg, or to Mpox, at least at the primary facility, they should have the minimum kits readily available so that they can use them, and to ensure that we don't have shortages. Similarly, at the secondary and tertiary cell level, where the demands are a bit higher, because we are saying at least we should have adequate single isolation rooms, or if it's not possible, at least one room for cohorting. We have sufficient sanitation facilities for inpatients who are admitted, functional hand hygiene at all points of care for toilets and service areas, adequate bins in all service areas that allow proper healthcare waste management and segregation. And we have dedicated special area for decontamination. And similarly, we have adequate ventilation in our healthcare facilities, and also sufficient supplies. As I mentioned, we should have the basic minimum packages available for PPE and equipment and power available in our healthcare facilities. So we are saying that assessments that we do should be in the spirit of improvements, and we must have regular assessments of these minimum requirements to ensure that we are continuously improving. And assessment, it helps us to create a sense of agency to ensure that we are constantly improving, we identify our existing strengths, and we're able to make progress for that. And as I already mentioned, we have validated tools which you can use for assessing these minimum requirements at the national and facility level. With that, I thank you. I hope these have been clear, as we need to start reporting on an annual basis on these minimum requirements at the facility and national level. Thank you so much. I will now hand over to Dr. Landry, who's going to move on to the next presentation on the infection prevention and control assessment tool at the national level. Over to you, Dr. Kabego.
Thank you so much, Ms. Tendai. So our colleague Anthony Twyman has joined us, so he's going to make this presentation on the infection prevention and control assessment tool, which is a tool to assess the IPC programs at national level. Over to you, Anthony.
Thank you so much, Dr. Landry. Just to confirm, everyone can hear me okay?
Yes, we can hear you. Okay.
I will go ahead and share screen. And whoop. Okay. All right. So thank you so much, Tendai, for the introduction into the minimum requirements. So hopefully people on the call today have a sense of what kind of things need to be in place at a minimum level. And at WHO, we actually have a number of tools to sort of complement this and allow you to evaluate what your program looks like at a national level and at a facility level according to the various types. So here we're just going to focus on the national level for right now. We can definitely pop the link in the chat so where you can download this tool. But please do pop in the Q&A if any of these indicators are confusing to you, or if you don't understand exactly how you would assess it, we can always maybe help answer and give some context. So let's go right into this. So the purpose of the national level tool is really to look at the IPC program implementation at national level. Of course, there's going to be linkages to the facility level, but we are only looking at national level with this tool. These minimum requirements, as Tendai has just explained very well, come from the core components that we should all be familiar with already. If you are unfamiliar with the core component guidelines, you do want to have a look at that before using these tools, because it is important to understand what is the main goal that we're working towards. And when Tendai showed that mountain, the orange and purple or blue larger square, triangle, sorry, we're working to the top of that mountain, and that's what the core component guidelines represent. And so to have an understanding of how all these things link together and build on one another, you need that before going into the minimum requirements. So hopefully the image on the right will look very familiar. We just saw it a few moments ago, and this is the 5-step cycle that's recommended by WHO when taking on these assessments, or really any IPC implementation for that matter. We want to look at exactly where do we stand. And so this tool, this national level minimum requirements assessment tool, will help you with both step 2 and step 4. So it'll give you a baseline of where you start when you first use it, and then you can repeat this probably not less than every 6 months, but maybe even up to 1 year or per year. It sort of depends on, you know, how long it may take to make some changes or improvements, but you'll essentially have your baseline and be able to track your journey of impact as you progress. Who should be completing these tools? It's the National IPC Committee alongside the IPC National Focal Point. It could be also with the IPC stakeholders. So you may need to have discussions or engagement with other members who may not be directly involved in IPC, but may have impact on how you implement IPC. And the last bullet there is really the easiest way to summarize it, is basically anyone responsible for organizing and implementing IPC will be involved in this process. How is it structured? How do we use it? We're going to get into looking at the structure a bit more. You've already had some insight from Tendai just moments ago, but this tool is probably one of the shortest assessment tools ever released by WHO, with only 6 sections, so 6 core components at the national level with 25 indicators. And so it's important to remember that at national level, there are only 6 core components, whereas the facility actually has 8 core components. So again, this is where we really want to underscore the importance of being familiar with the guidelines because it will also help understand why these tools can look different across different levels. The indicators are based on evidence and expert consensus and are all framed as statements. As these are minimum requirements, all indicators have to be met to officially meet minimum requirements. So that would be a score of 100%. Anything less than 100%, you would deem not met. That isn't to be punishable or to be mean, but I think as Tendai just explained, minimum requirements are the minimum level of safety. And if we don't have the minimum level of safety fully implemented, then we can't say that we meet the minimum requirements. The total score will be the sum of all yes responses for each core component, and they are weighted based on the number of indicators within each of those sections. Each yes should be based on physical evidence or some proof that in fact it is implemented. If there is any absence of physical proof, a broad consultation with stakeholders is necessary to figure out where exactly are you. And of course, if there's any part of the indicator that you feel like, well, we have some of it, but not all of it, then you will answer a no and sort of deem it as non-compliant. But again, that should not be taken as a negative, as all of this is done in the vein of quality improvement. So we're doing this for the purposes of improvement. None of this is meant to be punitive. In practice, how does this look? For each indicator, you want an exhaustive evaluation of the whole sentence. And I really like this first bullet. It really is about unpacking what is the indicator asking for, and are all of those elements actually met? You want to think about the objective of that indicator. What is it really asking you, or what is it asking you to look at and reflect on with your own IPC program? And so if you believe that one or more concrete actions are still necessary to completely meet the standard, it is advisable to answer no in order to take the necessary measures. And this, again, is part of that quality improvement journey. And so hopefully those no's will turn to yeses over the course of time. And that in itself is a great success story. And we heard some of this last week with Togo and Malawi, presenting where they've now come many years after working on implementing their programs. Always think that a yes answer means that the country has completely met the standard, and no means that action remains to be taken. So core component 1, our IPC programs. I'm not going to run through all of these right now, given that Tendai just did a great job presenting many of the minimum requirements, but I will pick out a few that often we get some questions on. And of course, if there are more questions, please do pop them in the Q&A. So if we look at the very first indicator here, an active infection prevention and control program exists at the national level. And what you'll see in red is that there's actually a footnote or definition given to what active means. So this is defined as a functioning program with annual work plans and budget. So if you have the work plans, but you don't have the budget, you would indicate a no for this answer, or for this indicator, sorry. If you have the budget, but not the work plan, it would still be a no. So again, the elements have to come together in order for you to have achieved it. You can see here that if we look at the very last one, the appointed IPC focal points have dedicated time for the tasks. And in brackets, we define this as at least one full-time equivalent. So in many other countries, we know that IPC focal points are often shared roles with other responsibilities. We would argue that that is a no in compliance with indicator 5 under core component 1. So again, it is about taking your situation and being reflective in a very honest manner of where you stand across these. For core component 2, IPC guidelines, here you have a total of 5 minimum requirements. And I believe Tendai was making some great points, especially on the guidelines. If we look at number 4, these are meant to be reviewed at least once every 5 years and updated to reflect the current evidence base. So that could look as simple as you have your guidelines and you have a date of when they were first published, and perhaps you could even add an insert that would indicate when the subsequent updates occur, or maybe it's specific chapters that you can only update or need updating, and you indicate what those changes are. I can pop in a link actually from an example. I come from Canada originally, and they have a great way of spelling out how they showcase what changes they make, what has been affected or not. And it's just a very clear one page right at the outset of the guideline to indicate these are what actions we have taken since this publication. Maybe you have this already, and if you do, then you would definitely meet this requirement. But I think it's about just appreciating that it is a lot of work. And so you can also be strategic in how you approach some of these. If we look at number 2, the development of guidelines involves the use of evidence-based scientific knowledge and international national standards. Here you might be looking for what references are used within the guidelines. Are these references current? Are they from the 80s and we're in 2025? Are we using the most recent international publications? So WHO, especially all the work from the IPC team, they have included a lot of their systematic reviews and evidence available. So they've done some of this work for you already that you can easily lift and adopt to your context. Number 3, the guidelines are for national coverage. So they should be including all acute healthcare facilities, both public and private. This one sometimes can get a bit complicated depending on how your health system is structured. And in some cases, you know, if private facilities are arbitrarily excluded in certain laws or other things, I mean, this will be a very hard indicator to change at any sort of quick frequency. But I think, again, it's not about getting caught up always in the details and just assessing your situation honestly, but then also noting what are the gaps and maybe what are some of those barriers to implementation, and slowly chipping away at how you might approach that, as some interventions could be long-term. Core component 3, IPC education and training. So here we have a total of 4 indicators. And this is when I was talking about linkages to facility level. This indicator in particular has a lot of that embedded in it. So here you can see, even if we look at number 2, the National IPC program provides content and support for IPC training of health workers at facility level. So again, this could be that the national level sets the core competencies for health workers and what training they need and at what frequency. So again, impacting on the facility level directly, but maybe doesn't, you know, always develop every single piece of training material. Some of that could be done at a subnational level, but sort of the skeleton structure and what is needed and required is defined at national level. If we look at indicator 3, a national IPC curriculum for in-service training of health workers has been developed in alignment with the national guidelines, approved and endorsed by an appropriate national body. So again, footnotes here. This will depend on the local situation. This could be a department dedicated to training and education within the Ministry of Health. It could be a department dedicated to the training of health within the Ministry of Education, or even a national professional society mandated by the Ministry of Health. So multiple solutions here to meet this. It's not necessarily just in one strict sense. But again, there needs to be a curriculum developed that outlines what competencies need to be there. And I think AFRO had spoken to in the last webinar about having such a guideline available for in-service training, curriculum development. So again, there are tools there already for you that you can lift and then figure out who is responsible for overseeing this implementation, engaging with them, and making sure these things are embedded. Core component 4, HAI surveillance. This only has 3 indicators. And to be fair, it's less so on the actual implementation. Again, we're only talking about the minimum. If you have more implementation than what is here, that is fantastic, and we hope that is the case. We are only focused on what is absolutely necessary to have at a minimum level. So here it's really about having that multidisciplinary technical group established and created at national level, having a plan for what that healthcare associated infection surveillance will look like. And this should be based on the local context with priority infections identified. So there is no wrong answer to what infections, so long as that they are in fact the ones that make sense for your context. The National IPC Focal Point team is trained in HAI surveillance concepts and methodology. So do you in fact have the competency to oversee national level HAI surveillance? Core component 5, multimodal strategies for implementing IPC interventions. So again, here there are only 3. You should have someone who's trained on the knowledge of multimodal strategies. And again, there is a footnote. That is what's denoted with this 2 asterisks or 2 stars. And that is, I think Tendai actually covered this in her presentation already of what multimodal means, about having those 5 various elements. If you call it something else, that's also fine. We don't have to always get caught up on it just having one name. There are many other groups that call it different things. I think WASH has the 5 Ws, I want to say, which again, they're all similar frameworks. So if you have any kind of one of those, it would still meet this requirement. The National IPC Focal Point coordinates and supports the local implementation of IPC improvement interventions. So some level of coordination or oversight. And multimodal strategies are included as the best approach for implementing IPC guidelines in education. So even at a national level, when you're developing the guidelines or developing the curriculum, you're already embedding this idea of multimodal intervention or interviewing. And the last core component is number 6. So monitoring and auditing of IPC practices and feedback. Here we have a total of 5. Looking at having that multidisciplinary technical group. So if you have an IPC national committee, chances are you're going to meet this. It could be a part of that or a sub-working group. You're going to have a strategic plan in place. So this can be linked to an HAI surveillance plan as well. You could have them as a combined plan with the different sections looking at outcome indicators, but also process indicators. You're going to have a minimum set of indicators for health facilities for the country to report on. So the facilities should already know what you're looking for them to actually relay back to you as the information. A mechanism to train the local and national auditors. So having people with the competency to be able to actually educate and facilitate that implementation. And hand hygiene is recommended as one key national indicator, at the very least for your reference hospitals. So you may not have every single facility reporting on this, but you will need to have it at the basically the highest level of care in your country. And this is a process indicator. So this would fit into your process, your monitoring and auditing of IPC practices plan for your country. when it comes to the summarizing of your score, pretty straightforward. It is going to just be the total yes responses. You see the maximum score on the right. I believe there's even a little embedding that you can do, so it can just be automated. But you take the sum of all yeses across your 6 sections, and you have a total that will give you an idea of what percentage you have. So again, it's going to come down to officially meeting requirements is 100%. Anything below will be unmet. But I hope that is not discouraging when engaging with your stakeholders or other partners, but rather one that can be seen as an encouraging journey to watch the growth over time and to be able to showcase the hard work that you're doing in advancing your IPC program implementation. And with that, I stop there and say a big thank you and hand back to our moderator.
Thank you very much, Anthony, for the brilliant presentation. And now we are going to move into the first session for our question and answer. And I'm going to kindly request if you can raise a hand and we'll allow you to be able to unmute. Also note that we are just going to give you at least 1 minute to to ask your question. If it's a reaction or if it's a feedback, you can comment, but let's try to stick to time. So colleagues, the floor is now open. We have gone through the minimum requirements at the national and the facility level. We have also gone through the tool, which is what we are recommending, that with this tool, we use it on an annual basis or at least 6 months to review the progress that we are making with our national action plans so that we reprioritize activities and try to ensure that at least we have the basics, the wheels in place, the core components in place. Colleagues, over to you. And also, if you have joined using another link, may you kindly rename yourself. We are seeing names A17. Kindly rename yourself and put your name. There's a Timothy Odi where you can start by introducing yourself and make sure you stick to the time for asking the question. May you kindly unmute, allow Timothy to unmute. Go ahead, Timothy.
Bonjour, vous m'entendez?
Oui, on t'entend, Timothée, tu peux y
Vous
aller.
m'entendez bien? Bonjour à toutes et à tous. Moi, c'est Timothée Audi. Je suis le point focal national PCI au niveau de la Côte d'Ivoire, également président du comité technique national PCI. Alors, j'ai deux préoccupations. La première concerne la composante principale surveillance des infections associées aux soins. Alors, je voudrais vraiment faire un plaidoyer pour que nous puissions avoir une formation. Je vais parler de tous les points focaux PCI des différents pays. Si on peut nous donner une formation sur la surveillance des infections associées aux soins. C'est un aspect très important. Au niveau de la Côte d'Ivoire, nous n'avons pas encore pu mettre en place quelque chose dans ce sens. Nous essayons, mais c'est compliqué. Donc, on souhaiterait vraiment avoir une formation sur la surveillance des infections associées aux soins pour pouvoir nous permettre vraiment d'avancer dans cette composante principale. La deuxième préoccupation concerne le deuxième outil qui a été présenté là, pour l'évaluation au niveau national. Alors, la première composante principale parle du programme PCI et de façon précise, on dit un programme actif PCI. Ça suppose qu'il faut avoir un plan de travail et un budget. Alors, à ce niveau, quand on parle de budget, de quel budget parle-t-on? Est-ce que c'est le budget de l'État ou bien le budget avec les partenaires? Voilà, je veux avoir cette précision-là. Parce qu'au niveau de la Côte d'Ivoire, on a du mal à avoir un budget de l'État pour travailler. Par contre, quelques partenaires nous accompagnent dans la mise en œuvre des activités de PCI. Donc, est-ce qu'il faut absolument avoir un budget de l'État pour dire qu'on a un programme actif PCI? Voilà un peu mes deux préoccupations. Je vous remercie.
Bon, je vais peut-être réagir à la première préoccupation et puis je vais passer la main à Anthony pour la deuxième. Pour la première, merci, c'est bien noté. Nous pensons l'année prochaine, nous allons faire une formation régionale sur ça. Nous avons un projet pilote que nous avions commencé. C'est un projet global, mondial pilote. Et il y a un pays de l'Afrique qui y participe. Et ce projet-là, c'est sur la mise en œuvre, effectivement, de la surveillance des infections associées aux soins. Et à partir de l'année prochaine, nous serons capables de, d'ajouter d'autres pays et d'élargir sur d'autres pays. Mais nous savons et nous notons bien que c'est une priorité pour vous. Merci. Anthony, à toi.
Yeah, thank you so much, Landry. And maybe if I can just add two things. So, sorry, my power went out. I didn't know if the internet was too. There is also the surveillance module. I'm not sure. I think that was translated into French, at least as a resource that maybe we can see and locate. In terms of the second question and the budget, so we don't define exactly how much money a budget should be, but we do expect that the budget is coming from the Ministry of Health. So if we only relied on partner funding, then that would always be external source, and there isn't full sustainability to that. There needs to be the accountability and ownership that the government is also adding funds to support IPC implementation. So what is really important to understand there is that in order to achieve an active program, you will need a budget that is domestically financed. We did have the colleagues from Togo and Malawi talk about their programs and how they do have funds now, but they didn't when they originally started. And I can't recall exactly, but I do believe it took a bit of time in order for them to get the funds and a lot of advocating and support from partners as well, not just on their own. So as much as we can appreciate partner funding, and yes, it's important to fill some other gaps, we can't say that the ministry doesn't have a role to play when financing their own teams as well. If other colleagues would like to add, please do.
Thank you very much, Anthony and Dr. Landry, for the elaboration. And indeed, to just emphasize that we advocate for dedicated budget. And as we said, it's a progressive, we do it progressively, and we can now start building an investment case. I think in the last session we had, there was a recommendation on building investment cases. And as the national program, you can start doing that as well at the national level, advocating with your government and engage them in your activities so that they understand the importance of IPC and are able to dedicate finances. Prof. Babaka, I don't know if you want to comment on this. Also, if we have questions, we can put in the Q&A so we can make it more interactive. Prof. Babaka, over to you. I will wait for other hands.
Merci beaucoup, Tendai. Je vais m'exprimer en français parce que je suis plus à l'aise en français. En fait, pour cette question de budget, c'est un problème très général en Afrique. Et je vais juste donner l'exemple d'un pays comme le Togo, qui, avant même d'avoir un programme actif, avait déjà prévu de l'argent, un forfait pour la PCI. Donc, c'est une question de commitment et de décision au plus haut niveau. Du côté de l'OMS, il y a aussi des outils qui permettent de vendre le programme en montrant aux décideurs les gains qu'il y a. Je donne juste un exemple précis. En investissant $1 sur la PCI, on fait un gain de $15 parce que l'inaction peut coûter. Les infections associées aux soins ont un impact financier, augmente les dépenses, un impact social, un impact économique parce que les gens qui sont malades ne travaillent pas. Donc, ça, c'est un travail à continuer, à persévérer. Merci beaucoup.
Thank you very much, Dr. Prof. Babaka, for emphasizing on that. I also see in the chat box, there's a comment that is saying most countries don't have a budget for IPC. They see IPC as an investment going into the drains. They prefer drugs. They prefer, probably, I assume it's ordering drugs, revolving funds. I think this is why it's important when we build an investment case, when we show that IPC reduces the incidence of healthcare associated infections. It's also critical for reducing antimicrobial resistance and also the length of stay in healthcare facilities. We help them to understand why it's important to, in the long run, to invest in IPC and also to save on costs. Then secondly, there is also a question on the Q&A moving on, which was asking if the tool that Dr. Anthony presented is relevant for the facility level. No, the tool that was presented by Anthony is specifically for national level programs. It's for assessing IPC programs at the national level. The tool to assess at the facility level is called the Infection Prevention Control Assessment facility level. For minimum requirements, we have tools that allow us to assess at the primary, secondary, and tertiary level. And as part of the package, when we are disseminating the training materials, we also add these tools so that you are aware. I don't know if Dr. Catherine Buyane, if you want to ask your question live, it will be the last question. You can allow Catherine to unmute. Please stick to 1 minute to ask the question.
Good afternoon, and thank you so much for the opportunity. I think my question is nearly aligned to the previous speaker. I'm in South Africa. IPC is not really well considered. I had already put in question in Q&A to say, how would you come in and give us support in this regard by maybe presenting to the leadership, showing, indicating to them what IPC is all about, including the organizational structure that has been proposed and how could they go about budgeting for it. I think that will help a great deal. It will improve how IPC is being considered. Thank you so much.
Thank you very much, Catherine, on that question. I don't know, Anthony, if you don't want to take that up first.
I mean, what I can say is this. I think what WHO has been doing in the past is trying to create resources that you can use to convince your own government. I think it is obviously very tough to get to everyone's government specifically and present individually, versus at least at a sort of global and regional level, supplying the materials and putting some of these briefs together for you that you can use. That isn't to say that having direct conversations are not possible. I know, in fact, from AFRO, Landry and Tendai are doing exactly this for countries where they are actively engaged and prioritizing actions as part of their work plan. So I think these things can be noted and taken on board as something to follow up on and see how we can, as collective AFRO colleagues, support you as the national leads. But I think it's also important that we make full use of all of these resources that are being published so that some of these actions that you can take are making sure that it speaks the right language within your country. Because you know your country best, better than we will ever know it, no matter how much we work and support you with. So we do want to make sure you feel that you're empowered and in that driver's seat. But please, Tendai or Landry, if you want to comment further on your own work that you've done, as I know you have actively done similar asks perhaps, but maybe not exactly what Catherine has proposed. Over.
Thanks, Landry, over to you.
Yeah, just to add, if the country needs any support, even when it comes to advocacy, you know how to request technical support from WHO just through the WHO representative of the country. So as we are available for any support if the request is sent. Thank you, and over to you.
Thank you very much. Indeed, Dr. Catherine, we would be more than happy to support countries based on their requests. And also currently, we have, you are already implementing at some level in the different countries. It is important that we have all that data in place in the different provinces where they are doing healthcare-associated infection surveillance, where they have shown how it has impacted they reduce the incidence of highs when they have properly implemented IPC. Even some of the context-relevant experiences within the country will help to build a case on how IPC, how we can advocate for support on the organization and the structure and funding for IPC. So colleagues, thank you so much. I think as we continue with the discussions, let's continue, keep them coming in the Q&A. I'm now going to move on to the next session, and we'll have another Q&A after that, where we'll continue interacting. I'm going to invite Dr. Bobson Fofana, who is the Infection Prevention Control Officer with the World Health Organization from Sierra Leone, to showcase the experience that they have used on IPC assessments using the IPCAF-MR, the facility assessment, which is based on minimum requirements for facility level. Dr. Bobson, over to you.
So good morning, good afternoon, colleagues online. Thank you very much, Tendai, and the colleagues at the AFRO team for this wonderful opportunity to share experience from Sierra Leone, like always. So I will be sharing my screen. Please permit me, and please confirm if you can hear me loud and clear.
We can hear you loud and clear, but we are still waiting for your presentation.
It's coming up. Okay. So it should be visible now and in PowerPoint mode.
Yes, we are waiting for the slideshow. And also remember you have 15 minutes, Bobson.
Okay, I will be very fast with this. So please confirm now it's in PowerPoint mode.
Yes, go ahead. Thank you.
Okay, so I'll be turning off my video, so also to have a better bandwidth. I'm putting on a cap because we are also complementing the AMR effort as part of the AMR Awareness Week. Okay, so I'll be sharing with you results or findings from our recent assessment, performance assessment of IPC program in Sierra Leone. This actually includes the national IPC program and also across health facilities. So I am Bobson Derek Fofana. I work with the WHO Country Office as the IPC focal point. So the outline will be to share the results, findings, but part of it also I'll be explaining how we go about to do the assessment and also some of the key gaps, including the performance scores and also some of the recommendations for action. So the main purpose of conducting the assessment, like the previous two speakers, Tendai and Anthony, I think they made the work very easy by explaining in detail the assessment checklist, which is the IPCAF minimum requirement and also the IPCAT minimum requirement for the health facility and also for the national IPC program, respectively. So we need to assess our current status of achieving those minimum requirements at the health facility and the national level, but also to help us document those strengths and gaps, which will help us prioritize our plan, especially as we move into a new year. and this goes along with evidence-based recommendation. So I will not speak much on the tool itself. It has been discussed lengthily by Tendai and Anthony, but just to mention that we conducted assessment of the national program, which is the IPC unit, using the CAT minimum requirements tool, which has about 25 indicators. And also we assess healthcare facilities, about 34 healthcare facilities across 4 regions, which include 24 secondary and 10 tertiary. So each of those, we use the specific facility level tools to assess those hospitals. So this was recent assessment between August to September. And also it was joint assessment with the national IPC program units and also the IPC team. And to some extent, we even complement it with AMS assessment along the line. And the tool we use were the ones I made mention of and which we have presented earlier, but also there is a digitized version of the IPCAF assessment tool for the hospitals in Kobo, which was developed by the AFRO team. And we also have the Excel version of the IPC National Assessment tool. So this is the result for the National IPC assessment. There are 6 components, and each of it has allocated points and scores based on yes or no response. So for among the 6 components, already we have achieved 2 of the components fully, which is IPC program and the multimodal strategies. But we also have significant improvement in IPC program as in component 1. So we still have 4 of the components to be achieved at the moment, and we are at 72%, which shows that we have achieved 72% of the minimum requirement at the national IPC program level. So we further went on to compare this. So we have done previous national IPC assessment. The first one was in 2023 when we were developing our strategic plan for IPC. By that time, we had AFRO colleague Tendai and also Professor Babaka, who we are also supporting the situation analysis. So part of it, we conduct the first minimum assessment of the IPC, of the national IPC program. So the overall score by then in 2023 was to 56%. And we went on to conduct another assessment in 2024. We got 64% overall. And this recent one we just completed, we have got 72%. So it shows there is a linear increase in IPC performance at the national level, but mostly so if you see the radar chart, you see expansion mostly on IPC guidelines, which initially we were at 80%, but moves on to 100%. And also from IPC program from 60% to 80%, and some aspect of IPC monitoring, all of course multimodal strategies has been there, but we see persistent gaps in IPC training and education and minimal improvement with HAI surveillance. So for the health facility assessment, among the 34 hospitals, there were 24 secondary facilities and there were 10 tertiary hospitals. And among these also, they were from 5 districts of Sierra Leone. You see, most of them were actually from the western area. 14 of those hospitals were from western area. So when we look at all these hospitals, we noted that there is a huge disparities in the performance status, irrespective of their levels. But we noted that most of the tertiary hospitals were doing better. 2 of them actually are the first one, Connaught and PCMH. And we have Koidu, who is also a secondary hospital, but also because of we can relate to certain partnership work by certain partner in that particular hospital, we noted that that can be attributed to some of their improvement, but we're also seeing some other secondary hospital having good performance scores. So this is just a snapshot of the scores across all 34 hospitals. And when you look at the distribution, there's an average of 60%, but also you notice that there are some facilities who actually they are perform extremely well, which even goes beyond the about 4 standard deviation of the mean itself. So most of the facilities were between 50 to 70% generally in terms of their average scores. And you see also there are extreme ones like those performing poorly within the range of about 30 to 40% in terms of their scores. So in terms of when we group according to the levels, we noted that 73% of or 75% of the facilities or majority of these health facilities are actually between the range of what we may determine as intermediate between 50 to 75. In as much as we want to achieve absolute, which is 100% of the minimum as a bare minimum itself, but we also put it into 3 categories to see how progressive some of these facilities are, which are in terms of basic, intermediate, and also advanced level, which is above 75 threshold. So we noted only about 12% of these facilities have reached that, while we still have a good number of about 15% are still below 50% in their performance scores. This is just general view of how they are presented also according to district, but most of, again, the facilities that are not really doing well are also found in the western area, because most likely because there are large number of health facilities reported in this study. So when we look at component-wise average across all healthcare facilities, we've seen significant improvement in terms of multimodal strategies that is being adopted in health facilities, but also monitoring practices of IPC indicators specifically. And also we see good performance in terms of IPC program. You agree that most of the health facilities do now have, or all of the health facilities do now have IPC program, despite the persistent gaps of not having a dedicated budget in most of these facilities. But also persistent gaps have been there in terms of healthcare associated infection of just about 22% of those health facilities. This also justify, the explanation made by Tendai that globally or regionally there are issues or persistent gaps with implementing healthcare associated infection. So this justify contextually the situation in Sierra Leone. So if we zoom in into HAI issues, we noted that among the secondary health facilities, only 4 of them are actually implementing a form of healthcare associated infection surveillance system being in place, and where we have 20 of them not being implemented. While at the tertiary level also, you see variations in the indicators of HAI, but mostly are actually not doing well, except for personnel that are there, which are the IPC focal that will be responsible for conducting HAI activities across their health facilities. So summarizing the gaps and strength also, so you see in the white highlight the strength, and also in the orange ones you see the gaps. These are mostly general gaps that applies. So for the national program unit, there is existence of IPC program with all the structures and all the strategic document for and guidance framework. But also there is also gaps in terms of having a dedicated allocated budget for IPC. While there is some amount of fund allocated minimally to support operational cost, which is mostly below about $2,000 or so annually, which mostly for running the program administratively, but these are not geared towards supporting implementation of IPC action plan. So IPC guidelines are there. We are at 100% in terms of IPC guidelines, accessible and implemented across both private and public facilities. And in terms of training, there are consistent IPC training undertaken, but there are still issues around in-service training program and also lack of evaluation on the effectiveness of training, which is being monitored within the framework of the national program. While multimodal strategy is implemented, even within the national IPC guideline structures implementation of multimodal strategies, there are still gaps again around HAI surveillance. So the country, we have just developed HAI surveillance strategic plan, which is there. I think that is one of the reasons we have moved in scores from last year to this year in terms of HAI, but there is still not in place a systematic HAI implementation in terms of putting the action itself, putting the plan into action, and we have not developed a technical working group for that yet. M&E is the same. While there is a M&E working group, there is lack of strategic plan for monitoring and also training of auditors in terms of IPC indicators. So for the health facility level, the IPC program exists also with full-time focal point, but there are issues with budget. And also in terms of guidelines are there, but there are still also issues around adopting those standard operating procedures, facility-based SOPs on standard and transmission-based precautions at the health facility levels. So which means there's need for more capacity building for adoption of SOPs. Then training of personnel can be led by IPC program as a strength in all of these facilities, but however, limited training of health workers for those who benefit from healthcare or from IPC training is still limited in the country, and that calls for more specific training also for IPC focal point. And lack of structures and resources for HAI surveillance, like laboratory. There are only few hospitals that can perform microbial surveillance for AMR, which we are leveraging on. So there's still gap within this area of surveillance of healthcare-associated infection. Then periodic audits done by trained personnel, but there's inconsistency in terms of having a systematic way of reporting on IPC indicators from the health facility level and also providing feedback as necessary. And the issues around built environment, workload, and staffing is inevitable to some extent. There is still low health workforce, which impede, the aspect of workload, staffing, and all those things. But also poor hospital infrastructures also impede issues around isolation structures, triage, cleaning, infrastructure for sterilization, waste, and incineration system. And also the issue of persistent stockout of IPC supplies remains the same. So there are few priority recommendations. We cannot bring them all, but for the national level, you appreciate that there is need for funding allocation for implementation of IPC program, even at the facility level also, but also for the national to support institutionalization of in-service IPC curriculum and also monitoring of IPC training effectiveness, while we also look into leveraging opportunities with AMR surveillance to implement a systematic HAI system or surveillance, and also establishing a technical working group for HAI. And in terms of M&E, to also see how the national and hospital auditors can be equipped with the necessary knowledge and skills also to conduct or actually perform audit and frequent, consistent monitoring of health facility, and also measuring of the IPC KPIs at the national level. And also to involve in some aspect of operational research, which we have seen also can be useful to support, to facilitate action. Some of these we believe can actually drive action for even things like funding gap. So we also look into that as a key suggestions. But for the facility level, besides the dedicated budget, there is also need for expert mentorship of IPC focal for them to be competent enough to adopt also SOPs on standard transmission-based precaution tailored to their facility needs, but also expand IPC training for healthcare worker, which means there's need for more additional IPC training, competency-based training for health workers and cleaners. And we're also looking towards having at least the tertiary health facilities conducting HAI surveillance and routine performance monitoring of IPC. Also, if there's opportunity, we look into integrating into the national system for health management like the DHIS2. And finally, to enhance the health facility effectiveness for waste screening and isolation, including supplies of IPC commodities. So in brief, I want to thank the National IPC Program, the WHO Country Office, and the WHO AFRO for their collaborative effort in also supporting the implementation of IPC program in Sierra Leone. Thank you very much. Over to you, Tendai.
Thank you very much, Dr. Bobson, for sharing the wonderful experience from Sierra Leone and the progression from the first time we did the assessment using the IPCAT MRA and the progress that has been achieved so far. I see people are reacting to your presentation. Thank you so much. Again, we are going now to open the floor for questions. If you have any particular questions that you want to ask the team from Sierra Leone on the presentation that they have made, feel free to raise your hand and you'll be allowed to unmute and ask your question. Or just to comment as you're waiting for hands to come up. I see that already you have from your presentation, Dr. Bobson, you already have a multidisciplinary working group for the 6th core component on monitoring IPC in healthcare facilities. And that same technical working group, I'm sure, can be used again for the for the healthcare associated infection surveillance component. I don't know if there are any questions, colleagues. You feel free to raise your hands to ask questions and provide any feedback or any questions you may want, even from the previous presentations that we made, myself and Anthony and also Dr. Bobson, to make it interactive. But in the meantime, I think there was a question from in the Q&A. As we wait for hands, there was a question from Chimwemwe Manga. I don't know if we should give you an opportunity to speak. Chimwemwe Manga, I think she's from Malawi or Zambia, between the two countries. I don't know if you want to speak on any of the questions. Chimwenge Mamba, go ahead, you can talk. And I see there was another hand. I think that quickly went down from, was it? Okay. My apologies, there's a Mario. Maybe you can be allowed to unmute. We give you a chance. Sorry, my apologies. I don't know how to pronounce your name. Mario Bev. Yeah, Landry, help.
Yes, Mauro.
Oui,
À toi.
bonjour. Vous me recevez?
Bonjour. Oui, oui, 5 sur 5.
Alors?
Oui, allez-y, on vous reçoit.
Ok, bon, bonjour. Je remercie vraiment M. Gobson pour sa présentation. Bon, moi, c'est pas pour sa présentation, mais j'ai un peu de préoccupation. Et ici, bon, je me présente, je suis d'abord Mauro, je suis au niveau bureau pays de l'OMS. Et c'est par rapport aux questions de programme PCI. Et ici, nous avons un peu de soucis parce que avec le ministère, quand tu parles programme PCI, ils te font sortir un document, ils disent qu'ils ont un programme PCI. Et on a un peu discuté sur ça et pour moi, je pensais qu'un programme PCI, ce n'était pas un document qui est structuré, mais c'était une entité. Mais bon, leur compréhension, ils disent que pour eux, pour le programme PCI, c'est un document. Donc, c'est pourquoi j'ai posé la question pour savoir est-ce que le programme PCI, c'est un document ou bien c'est une institution? Merci. Je voulais avoir des éclaircissements. Merci.
Bon, je vais peut-être répondre à ça. Le programme PCI, il contient plusieurs choses. Il contient un plan opérationnel, il contient le budget, il contient les ressources humaines, il contient les législations et tout ça. Tout ça vont ensemble pour former un programme qui soit viable à long terme et capable de délivrer ce qu'il doit délivrer. Donc, généralement, vous développez votre plan opérationnel qui est approuvé, peut-être au niveau du ministère de la Santé, et puis à partir du ministère de la Santé, euh, peut-être que le budget, il va être inclus dans le budget de la santé ou bien il y aura des votes à l'Assemblée. Donc, ça dépend d'un pays à un autre. Mais à la fin, il faut que vous puissiez avoir des législations qui vous donnent le mandat de mettre en œuvre les activités PCI. Et ça vous donne le pouvoir pour toutes ces activités-là. Il y a des pays où ils ont des décrets ministériels pour pour la formation euh, du programme PCI. Et ce décret-là va lister un peu comment est-ce que le programme sera structuré et quelles seront les prérogatives, les activités et les mandats couverts par ce programme-là. Je ne sais pas si Prof Babacar a quelque chose à ajouter sur ça. Je crois que c'est un élément très important où il faut vraiment donner toutes les précisions. Mais en fin de compte, ça va dépendre d'un pays à un autre. Chaque pays a sa manière de créer les programmes. Chaque pays a sa manière aussi et les étapes pour attribuer un budget à un programme nouvellement formé. Merci.
Bon, je crois que Landry, tu as tout résumé,
Prof
hein.
Babacar, tu as quelque chose à ajouter sur ça?
Oui, oui, je pense que tu as résumé l'essentiel, hein. Ça dépend des pays. Et il y a un nouveau document qui s'appelle le cadre juridique africain pour la PCI. Les pays doivent l'utiliser pour assurer l'institutionnalisation du programme. Voilà. Merci à vous.
Merci. Over to you, Tendai.
Thank you very much. I hope that provides clarity. I don't know if there are any other questions. I see people are putting some questions in the chat. Maybe I'll read some of them. And I don't know if colleagues have any other questions, if we have any feedback on what Bobson asked. Timothy, over to you. Please allow him to unmute. Please, a brief one from you, Timothy.
Oui, merci. J'ai deux petites questions. La première, je voudrais qu'il nous partage un peu l'expérience de la Sierra Leone, c'est-à-dire l'organisation de la PCI en Sierra Leone, s'il peut partager tout ça. Et puis la deuxième, quelle est la fréquence de
Timothy,
Allô?
ouais,
Ah,
deuxième question, on n'a
s'il
pas
vous plaît,
entendu, hein.
mon micro était fermé. Vous avez entendu la première question?
Oui,
Donc, je
oui.
reprends. La première, c'est, voilà, je voudrais qu'il partage un peu l'organisation de la PCI en Sierra Leone, hein, pour que chacun puisse avoir une idée. Et la deuxième, c'est pour voir la fréquence des évaluations avec les outils de l'OMS là, hein, en Sierra Leone. Est-ce que c'est 2 fois dans l'année, 1 fois dans l'année? Est-ce que voilà la fréquence? Merci.
Over to you, Derek. Do you want me to clarify or you got the questions?
I think if I get the questions clear, the first one is about the IPC organizational structure in Sierra Leone. And
Yes.
yes, and the second one is about the frequency of the assessment.
Yeah.
Yes. So for the IPC organizational structure, that is not something we can share now, but maybe subsequently or after this. So there is a structure for IPC program itself in Sierra Leone, and it was developed. It was established based on a policy post Ebola. It was in fact during Ebola. It was established by an act or a policy. So it's there within the Ministry of Health Central, and also now quite recently there is IPC program within the there is a National Public Health Agency also within which there is an IPC wing. So there is organizational structure within the Ministry of Health itself as the main body for IPC program in Sierra Leone. Yes. And for the frequency of assessment, so we do we have only done the assessment once since we started it in 2023, the IPC minimum requirement once a year for both the national and also for the health facilities. We want to make sure we cover as much as possible the health facilities and also the national. But in between that, we do other assessment for other processes within the framework of the key performance indicators we also look at. So for the minimum requirements, we do it at least once a year at the national and also at the various health facilities. But in between, we do other assessment, IPC assessment in health facilities using locally adapted tools, but all of which also speaks to most of those ones that are within the minimum requirements. Okay, I think that's it for now for the questions, except otherwise I'm missing any other. Over to you, Landry.
Yeah, over to you.
Thank you, Landry. Thank you so much, Bobson, for responding to that. Maybe before we let you off the hook, Bobson, there's a key question. How did you get 100% for multimodal strategies? Some explanation might assist us to understand. Also considering that on your weaknesses, you had so many issues on the infrastructure, and we are saying that as part of the building, the infrastructure is critical is the first component for the multimodal strategy. So how is it high when we have those challenges? Help people to understand. I'll come back to you, Anton, once Bobson is done on this one.
Okay, so I think for the built, I think again the built environment, the components 6 and 7 also are also very much independent of even the want for multimodal. But we all agree that multimodal, there is a package of intervention you want to have, but also the systems should be in place. So one aspect of the tool, I think, again, the way the tool is designed, because there are few questions on multimodal. In fact, I think for the secondary facility, there's only one question on multimodal. So which means you can easily get a 100% on multimodal, especially if the IPC focal point itself can be able to articulate and discuss around the implementation of the multimodal. Because in itself, you cannot assess tangible items itself of the multimodal strategy, but rather than just relying on most of what either you see and few of the things that you get as a feedback. I think it's the nature of the question itself. So for me, the multimodal itself is about the IPC focal itself appreciating and understanding and able to articulate and citing scenarios or situations where actually they implement the multimodal strategy. Otherwise, you will really not get to see the multimodal itself because it's not measurable to some extent as a tangible entity. I know it's a complex and quite confusing at times, especially for among all the other core components. Maybe I don't know, Anthony or one of the other colleagues can can also shed light on that. Thank you.
Thank you. I'll hand over to Anthony. Maybe he can comment on this as well as he had raised his hand. Anthony?
Yeah, thank you so much, Tendai, and thank you, Bobson, for the great presentation. I think to add on to this, so I think you made a very important point, Bobson. When you think of the MRs and when you're assessing them and you hit 100%, we don't want to interpret that as you've achieved the full implementation of that core component. So there is sort of a balancing act that maybe needs to happen when you report this out, that there is a difference between meeting minimum requirements and meeting the full requirement. So we don't want necessarily policymakers to think that just because you've met minimum requirements, it's 100%, you're done. No, we need to make sure that the messaging that we give back is very clear, that one is minimum and there's still more to do. I think for countries like Sierra Leone, where you meet the full minimum requirement, it would be a good idea to then look at the rest of the requirement in the full assessment tools to think about, well, what other actions can we take to continue progressing and just not forget about that there's still more. Not saying that's what you did, Bobson, but just sort of adding on that I think this is a way that we can always work around it and still incorporate other gaps for that if we feel that it's relevant. I just wanted to touch on the frequency as well. I think a shameless plug here is that WHO has been doing those surveys annually around the minimum requirements. So potentially when we see that come up for countries, that could be a good opportunity for yourself if you have not done this activity, to use that opportunity to understand where you are and also how you stand with other countries. And if you see other countries with similar scores or progressions, it could be a way for you to sort of reach out as well and share those experiences to learn how did you advocate for this or that. And that could be an interesting activity in the future to do where we pair countries to sort of, we had lots of talk about budget. Maybe we just bring countries to talk about how they made their advocacy just around budget. So different ways can be approached, but I think a lot of indicators take time to change. So to do it once a year is probably enough, but to do it, once every quarter, probably too frequently, because you'll just see no progression. And we don't want people to think that progress is stalled. So that's it from me. Thank you, Tendai.
Thank you very much for that, Anton. And also maybe just to emphasize as a reminder that we are saying the minimum requirements are the starting point. There are full core components that we are yet to achieve, and we are saying let's strive to put in place the minimum requirements first. And also maybe we should be able to discuss, we have seen these minimum requirements, how can we achieve them? It from your countries, how can we achieve them, what are the challenges, and how can we support you on achieving that? And with that in mind, I'm going to request Dr. Landry to present the summary of expectations, and then we'll close thereafter. Dr. Landry, over to you.
Thank you so much, Tendai. Let me share my screen. Okay. Thank you. Sorry. So I'm going to go through the summary of the key messages, but as well as the expectations from the member states. So during this webinar, we understood that IPC is one of the non-negotiable foundation of the international health regulations core capacities, and it is well central to building resilient health systems. So we need that the services that we are delivering to our patients to be safe and to avoid HAI. So with IPC, this help us to meet our targets. So to implement the IPC programs at national and facility level, we have the IPC core components, which are evidence-based, as my colleague said. And it's really important to follow these 8 core components at facility level and 6 at national level when we're implementing our IPC programs. And also the tool, the IPCAT minimum requirements, which is a tool that we use to assess the implementation of IPC program at national level, was presented. And this tool, as we said, has 6 core components. And just to let you know that there is a tool as well at facility level that the colleague from Sierra Leone used to present their healthcare facilities, which is called the IPCAF MR. In full, it's Infection Prevention and Control Assessment Framework Minimum Requirement. So this one is for facility level, and it's divided in 3 tools. One for tertiary hospital, another one for secondary, and the other one for primary healthcare facilities. So it's important to make the difference between the 2 tools. The one for national level, which contain only 6 core component, and then the other one as facility level, the IPCAF, which has 8 core components. And that's at facility level, you have 3 tools, one for tertiary, secondary, and one for primary level. So it's really important to understand that. And these 2 tools, they assess the minimum requirements. So when you feel like you have met the minimum requirements, you can go now and try to achieve the full requirements. And for that, you will use now the tool for the full requirements. But many of the countries in the region, many of them, they're in the process of starting implementing IPC programs. So they should use the minimum requirement tool. So Sierra Leone showed us that assessing and implementing targeted interventions can help to improve the implementation of IPC programs. So this is good, even though there were still some major gaps like the absence of the IPC budgets, but as well as gaps in HAI surveillance and education. Now, what can we ask you? What are the expectations from you? Actually, in 2024, in the World Health Assembly, the World Health Organization presented the Global Action Plan for Infection Prevention and Control. And this Global Action Plan was approved by the member states. So these are the core targets that your member states really approved in terms of monitoring the implementation of the Global Action Plan at country level. So let me go through the 8 core targets at global level. So the first one is to have an increase of proportion of countries with costed and approved national action plan and monitoring framework on IPC. So this is very important. So the action plan need to be costed and need to be submitted where it's going to be approved, because without budgets, it's really difficult to implement. And the second one is to have an increase of proportion of countries with legislations and regulation to address IPC, because we need some policies that need to regulate how and who is supposed to implement. So the third one is around the identification of protected and dedicated budgets. And then we have the increase of proportion of countries meeting all WHO IPC minimum requirements for IPC programs at national level. So we saw that Sierra Leone, they made not all the minimum requirements, they just made the minimum requirements for multimodal strategy and for another one that I've just forgotten. And the idea is to have for all the 6 continents to meet the 100% by 2030. And also an increase of proportion of countries with national IPC program at level 4 or 5 per the SPAR 9.1 core capacity, and level D and E in the tracks tool. So, and then the last one at global level is increase of the proportions of countries with basic water, sanitation, and hygiene and waste services in all healthcare facilities. Yeah, there was still another one, which is an increase of proportion of countries that have achieved their national targets on reducing HAI. And for this, you need to have to conduct a baseline study to see what are the burden, and according to the burden that you will find out in your countries, you can set up your targets on reducing HAI, for example, reducing SSI from 5% to 2%. So it's just going to depend on the epidemiology of your country and the findings. So at national level, there are also 4 targets that the member states have agreed to achieve by 2030. The first one is the increase of proportion of facilities meeting all WHO IPC minimal requirements for IPC programs. And the second, increasing the proportion of facilities with a dedicated and sufficient funding for waste services and activities. So this is mainly around the core components 8 and 7 on the built environment, the staffing, the workload, the infrastructure, the triage and isolation, the water, the hygiene, etc. And then here, the increase of proportion of facilities providing training to all frontline clinical and cleaning staff upon employment and annually, and 2 managers upon employment. So education in service training is also a key target that member state have approved to achieve. And this type of training should be implemented using as well the multimodal strategy that Mr. Tendai presented. It means you have your guidelines, your policy, you train people, and then you have the necessary infrastructure, you train people, and then you make sure that you do the monitoring and the evaluation, put in place some reminders of what you need to implement, and this help to change the behavior. I saw in the Q&A somebody asked the question, how our health workers, we have trained them, and during the training, they show that they really understand what our IPC measures need be to implement it. but when they are in the healthcare facilities, they are not implementing these measures. So it's a matter of behavior change, and using the multimodal strategy during these trainings can really help to improve the compliance of the implementation of some key IPC interventions. And then the last one is increase of proportion of tertiary, secondary healthcare facilities having an healthcare-associated infection and related antimicrobial resistance surveillance system. So this is another key component that member states have agreed to achieve by 2030. Thank you, and over to you, Mr. Ndai.
Thank you very much, Dr. Landry, for outlining the expectations. And I think it now makes sense on why were we talking about these minimum requirements, because now when we are reporting, we need to understand the key indicators that we are reporting on, and most importantly, beyond the reporting, to ensure that we build a resilient system. We cannot have IPC always being the weakest link each time we have an outbreak. We need to use this time to build the program, to put the minimum requirements in place so that when there is an outbreak and at the healthcare facility where it's starting, we do not lose our healthcare workers because they are not adequately supported or trained in IPC. So in a nutshell, ladies and gentlemen, this is what the session was all about. And I'm going now to close on behalf of Dr. Kapaya. He had to jump off for another meeting. And just to appreciate all the colleagues for joining, for your active participations, and for all the rich insights that we shared today. And I think from all the discussions that we have made one thing clear. IPC programs must be established, and programs are not documents. It requires human resources, it requires policies and procedures, it requires guidelines, it requires all the 8 core components that we discussed to move the cut of the IPC program, and they must be implemented, they must be monitored, and they must be sustained. As we move forward, I encourage all of us that we put the minimum requirements at the national level and the subnational and the facility levels, and ensuring that even at the primary care levels, we have strong IPC programs, as we said. At the primary level is the entryway to the whole healthcare systems, and they need also to be adequately capacitated and supported to implement infection prevention programs. And just to also re-echo that, the World Health Organization, the country offices, and at the regional offices will continue to directly engage with countries. Feel free to reach out to us so that we can provide you with the support that is tailored to your different contexts in different countries as we embark on this journey to strengthening what is already existing, and for those that are starting to see how we can best support the IPC programs. And now, as we have seen with the issues of budgets that were dominant in this meeting and healthcare associated surveillance, we need to ensure that we continue advocating for budgets, build investment cases, use the data that we are currently collecting with the minimal capacities that we have. Let us learn to use that data to build a case for us to support on infection prevention control, so that when there's an outbreak, we are able to respond effectively so that our patients are safe within the healthcare facilities, the healthcare workers, and their visitors as well. As well, to emphasize that working and collaborating with partners will be very important on this journey. We should continually work with partners, MEP partners, to ensure that the support that we're having is coordinated, not duplicated, and well effectively aligned with the national priorities. And as we end this session, let's forward the spirit of our theme. Let's not build and forget. Let's not build during an outbreak and forget the systems that we have built. But together, let's build, strengthen, and sustain IPC systems that deliver lasting impact. Thank you once again, and we look forward to continued collaboration and engagements as we progress. And in the next year, we'll continue with this engagement to keep the conversation is going on IPC and look at how we can support on the areas that have been raised in meetings. With that, ladies and gentlemen, thank you so much for your time. It's been a wonderful 2 hours, and it's great to see everyone is still there, and would appreciate your feedback on a survey that has been shared. Please be honest and objective on that survey, and to also look forward to that feedback so that we know what areas we can be engaging you on and also sharing insights on. With that, ladies and gentlemen, have a lovely week and enjoy the rest of November and festive seasons. Bye-bye. Thank you.
Hi, colleagues. Also, just to inform you, colleagues, that participants who attended both sessions are going to get an attestation of attendance. And this you will receive directly in your email next week. Thank you so much. Bye, colleagues.
Thank you. Bye-bye.
Everyone.